Hello everyone. During this lecture, we will talk about cardiovascular diseases. We'll talk about diseases of the blood vessels, and then we will discuss a few about diseases of the heart. Diseases of the blood vessels are subdivided into two broad categories. The first one is are associated with narrowing of the blood vessel or complete obstruction of the lumen of the blood vessel, either progressive like in atherosclerosis, which is a gradual process بشكل تدريجي, or suddenly like when a thrombus or an embolus occludes the blood vessel. The end result is cut off the blood supply to the corresponding organ with associated infarction or ischemia. The other category is the weakening of the vessel walls, بحيث إنه الvessel wall بصير ضعيف وفراجile, which can cause dilatation and rupture, which can lead to hemorrhage. And the causes for weakening of the vessel walls are usually either vasculitis or infections or aneurysmal dilatation. So let's start with atherosclerosis. Athero comes from the word atheroma, which is the accumulation of fat and fatty material and cholesterol in the walls of the blood vessels, اللي هي بالعربية أو بالعامية التصلب الشرايين due to تراكم الدهون في جدران هاي الشرايين. فاللي بيميز الاثيروسكلروسس هو intimal lesions. intimal يعني انها بتكون under the endothelial lining of the blood vessel. We call it atheroma or atherosclerotic plaques. So both are the same name for the same pathology. These protrude into the vascular lumen and they will cause narrowing of the vascular lumen, تضيق. فبالتالي decrease in the blood flow to the organs. These atherosclerotic plaques or atheromas are composed of a yellow core inside of cholesterol. This core is covered by a firm whitish fibrous cap. This is a picture of the atheroma in which you can see here the endothelial lining of the blood vessel. These are the endothelial cells. And here it is the muscular part of the artery. When we are talking about atherosclerosis, we are talking about arteries, الشرايين وليس الأوردة. And this is the atheroma. It is this yellowish color corresponds to the cholesterol and the fat, with associated macrophages engulfing the fatty droplets inside their cytoplasm. And it is composed of other cell types, inflammatory cells. Look how the intima is elevated. It's like a dome shaped, and it is covered by a fibrous cap. And the necrotic center containing the cholesterol deposition. So what are the complications associated with atherosclerosis? First of all, because it causes narrowing of the blood vessel, so it will cause an interference with the blood flow. So it will obstruct the blood flow and the blood flow to the organ becomes diminished وأقل من الطبيعي. Also, it can weaken the underlying media. يعني المسل layer of the artery بصير weak وبالتالي ممكن يصير في aneurysmal dilatation أو يعني كنتيجة complication of the atherosclerosis بصير في توسع كبير بالشريان وهذا أكتر شيء بصير بالأيورتا. The other complication is that this atherosclerotic plaque or atheroma with its cholesterol center may rupture. إذا صار أي event ممكن نتيجة elevated blood sugar, elevated blood pressure, any event that causes disruption of the endothelial covering of this plaque will cause the plaque to rupture. When this plaque rupture, it will cause a catastrophic event, which is the overlying thrombus or superimposed thrombus. فبصير rupture للبليك وبصير thrombus over it, and this thrombus will totally obstruct the blood flow. So في البداية ممكن يكون الأثيروسكلروسيس عامل like 70 or 60% obstruction, يعني في narrowing وتضيق والبلد فلو بيقل، لكن إذا صار rupture بصير superimposed thrombus and this thrombus رح تعمل total occlusion، وبالتالي يصير عندي إذا في البرين for example بتصير جلطة الدماغ أو الستروك، إذا في القلب بتصير جلطة القلب أو اللي هي الميوكارديال infarction، إذا في أي organ رح يصير في infarction in any organ. What are the risk factors for atherosclerosis? We have major institutional risk factors and we have modifiable risk factors. When I say constitutional, that means I cannot change it. يعني في أشياء ما بنقدر نغيرها، ما بنقدر نعملها أي modification حتى بالtreatment. Like first of all the age. It has a dominant influence on the risk of atherosclerosis and the risk of other cardiovascular diseases. The risk increases between the age of 40 to 60, and also it can increase after this. So the risk of cardiovascular diseases and atherosclerosis is very minimal in patients with a young age, like in their 20s and 30s, but it increases substantially after the age of 40. And the increase is more prominent even in men. So the incidence of myocardial infarction احتماليات الإصابة بالجلطات القلبية in men increases 5 folds 5 مرات أكثر في عمر ال40 ل 60 سنة. Another risk factor for cardiovascular diseases and for atherosclerosis, which is also constitutional and non-modifiable, is the gender. Premenopausal women are relatively protected against atherosclerosis before the age of 50, and they say that estrogen may have a protective role. However, after menopause, after the age of 50, when estrogen levels decreases substantially, the incidence of atherosclerosis and its related cardiovascular diseases increases, and with a greater age eventually may exceed that of men. So after the age of 50, maybe the men and women are affected equally, or sometimes the females affected more after the menopause. The third non-modifiable or constitutional risk factor is the genetics. So you can't change your genes. In some instances, the genetic factors relate to the familial clustering of other risk factors, like the patient has a family history, for example, of hypertension, or the patient has a family history of diabetes mellitus. So all of these diseases usually comes in families. فمعروف بيكون في عائلات بيكون احتمالية الإصابة عندهم بالضغط أو بالسكري عالي في familial clustering. فmaybe they carry some genes that are associated with these diseases. In addition, some diseases are definitely linked to certain genes and they are familial from the start, like for example familial hyperlipidemia and familial hypercholesterolemia, in which you inherit the gene for familial hyperlipidemia in your genome, and this will lead to the early occurrence of hyperlipidemia. Like hyperlipidemia, usually the risk of it increases with age, but in patients with familial hyperlipidemia, the disease starts at a very early age, like in the 20s or in the 30s, because the genetics are as such. Now we come to the major modifiable risk factors, not constitutional. Why we call them modifiable? Because we can affect them or modify them by treatments or by some lifestyle modifications. And this is the basis for the prevention of cardiovascular diseases and the prevention of atherosclerosis. The first one of these major risk factors is the hyperlipidemia, because atherosclerosis is associated with the deposition of cholesterol, and the increase in cholesterol in the blood carries a major role in the deposition of this cholesterol in the walls of these blood vessels. When I say hyperlipidemia or hypercholesterolemia, we have two types of cholesterol. The first one, the LDL, or the low density lipoprotein, which is called the bad cholesterol. It has an essential physiologic role in delivering the cholesterol to peripheral tissues. In contrast, we have another type of cholesterol, which is the good cholesterol, or we call it high density lipoprotein or HDL. This is a good cholesterol because it mobilizes the cholesterol from the atheromas, from atherosclerotic plaques, and it carries them to the liver where they are excreted in bile. So these both types of cholesterol, the LDL and the HDL, are important risk factors for atherosclerosis. When we have high levels of LDL, this is bad. And when we have low levels of HDL, this is bad. We should have high levels of HDL and low levels of LDL because the LDL is the bad cholesterol that is very much associated with with atherosclerosis and the risk for cardiovascular diseases. Some of the components of our diet affect the levels of our plasma cholesterol. The dietary intake of cholesterol containing products and saturated fat containing products like those present in the egg yolks, في البيض, في animal fats, في butter. For example, all of these will raise the LDL level, which is bad. However, the diets which are low in cholesterol or with higher ratios of polyunsaturated fatty acids اللي هي بنسميها البوفا اللي موجودة في الزيوت النباتية زي الأوليف oil for example, those can lower plasma bad cholesterol levels. Exercise, for example. So not only our diet affects our levels of cholesterol, but also the exercise. Exercise raises HDL levels and lowers the LDL levels. Also, obesity and smoking, it will raise the LDL levels and lower HDL levels. So to get the best of our diet and our exercise, we have to exercise more in order to and eat healthy food in order to lower our bad cholesterol levels in the blood. Another major modifiable risk factor that increases the risk of atherosclerosis is hypertension. Both systolic and diastolic levels are important in increasing the risk for atherosclerosis. And العلاقة كمان عكسية. Atherosclerosis also may lead to hypertension. So it comes in a vicious circle. Why? Because hypertension causes an injury to the endothelial cells lining the arteries, and this injury will lead to deposition of cholesterol under the endothelial cells. Other risk factor is the cigarette smoking. Prolonged smoking of one pack daily increases the death rate from ischemic heart disease by 200%. So it's a very high level and high percentage, and even smoking cessation reduces the risk substantially. What's the effect of smoking? Again, the smoking and its associated products and the hypoxia that it causes in the blood may lead to endothelial cell injury, so it will accelerate the deposition of cholesterol in the walls of the blood vessels. So smokers are at higher risk for atherosclerosis. The fourth risk factor is diabetes. Diabetes mellitus and the high levels of glucose in the blood also increases the endothelial injury in the arteries and leads to the deposition of cholesterol in the walls of the blood vessel. The incidence of myocardial infarction, which is a consequence of atherosclerosis, is twice as in non-diabetic individuals. And also the same applies for the risk of stroke, جلطة الدماغ, and gangrene of the lower extremities. That's why patients with diabetes are at higher risk for ischemia in the lower limbs, and that's why those patients usually get the diabetic foot. So it is a synergistic effect between diabetes and accelerating atherosclerosis, predisposing to ischemia and gangrene of the lower limbs. Um, Atherosclerotic plaques, the key process in atherosclerosis are intimal thickening, which will cause narrowing of the lumen of the blood vessel, in addition to lipid accumulation. So it's a gradual process that with the lumen of the blood vessel decreases gradually. These plaques can cause narrowing of the lumen, and they appear usually whitish to yellow in the walls of the blood vessels. However, these atherosclerotic lesions are not continuous lesions. They are patchy. So if we hold an artery, the atherosclerotic lesions will have a patchy distribution. يعني في area of atherosclerosis, بعدين normal area, بعدين area of atherosclerosis, and so on. Also, sometimes it only involves portion of the arterial wall, not the whole circumference of the arterial wall, especially in early lesions. طبعا مع disease progression, these lesions will get larger and become continuous and become occluding or involving the most of the blood vessel wall. What about the distribution of atheromas? Which are the most commonly affected blood vessels by atherosclerotic plaques? Abdominal aorta is typically much more frequently affected than thoracic aorta. So if we come to mention these blood vessels in descending order of frequency, meaning the most extensively involved to the least extensively involved, the lower abdominal aorta comes first, then the coronary arteries, الشرايين التاجية للقلب, then comes the popliteal arteries اللي في lower limbs, then comes the internal carotid arteries that carries the blood to the brain, and the vessels of the circle of Willis اللي هي بتكون موجودة at the base of the brain. Now, vessels of the upper limbs are usually spared. They are not affected by atherosclerosis, as are the mesenteric blood vessels اللي بتوصل الدم للأمعاء، والrenal arteries اللي توصل الدم للكدني, except these blood vessels are only affected by atherosclerosis at their ostia. شو يعني their ostia? At their area of bifurcation from the aorta. مكان اتصالهم بالأيورتا. This ostia is subjected to turbulent blood flow, so it is at risk for endothelial injury and atherosclerotic plaques. Now, what are the complications of atherosclerosis? ليش بنخاف من الأثيروسكلروسز؟ لأنه إذا هاي الأثيروسكلروتيك بليك صار فيها rupture or ulceration or erosion, it will lead to a superimposed thrombus formation, and this thrombus can either partially or completely occlude the lumen of the blood vessel, and this will lead to ischemia. If it is in the heart, we will get a myocardial infarction. If it is in the brain, we will get a stroke. If it is in the lower limbs, we will get a gangrene. The other complication of atherosclerosis is atheroembolism. إنه يطلع من هاي الأثيروما أو الثرومبس اللي بتكون superimposed عليها embolus. And this embolus حكينا عنها في محاضرة سابقة, and we talked about the systemic embolism. The other complication that mostly usually affects the aorta and the abdominal aorta is the aneurysm formation. Aneurysm formation means that the atherosclerotic plaque will lead to weakness of the underlying media of the blood vessel, فبصير جدار الارتري ضعيف، ولما يصير ضعيف وفراجايل بصير فيه dilatation بيتوسع. طبعا this dilatation or this aneurysm formation is at risk for what? It's at risk for rupture. وإذا صار في rupture، خصوصا إحنا عم نحكي هون عن الأيورتا، راح تصير في عنا catastrophic hemorrhage inside the body in the abdomen, and this can result in sudden death. So all of these are the complications of atherosclerosis, the acute complications. However, even the atherosclerosis itself will lead to gradual narrowing of the blood vessel, and this will result in chronic ischemia to the affected organs. So if it is in the heart, for example, ممكن البيشنت يصير يشكي من anginal chest pain اللي we will discuss it at the end of the lecture. Again, the symptomatic atherosclerotic disease, and I mentioned it before, the outcome depends on what blood vessel affected by the atherosclerosis. If it is in the coronary arteries, this will cause a myocardial infarction or anginal chest pain. If it is in the cerebral vessels, this will cause cerebral infarction, or what we call it a stroke, or can cause transient ischemic attacks اللي هي بيكون decreased blood flow للبرين بشكل عام. If it is in the lower extremities ممكن يصير عندنا gangrene of the legs. If it is an aortic aneurysm as a consequence of atherosclerosis of the aorta, this can lead to rupture and catastrophic bleeding. Now, how to prevent atherosclerosis? Prevention is divided into two types: primary prevention program and secondary prevention programs. The primary prevention programs are usually aimed at preventing atherosclerosis from happening from the start. بينما secondary preventing programs هي لما the patient when he experience one of the complications of atherosclerosis like myocardial infarction or stroke, the secondary prevention aims to prevent another attacks or another events, subsequent or secondary events. So let's go back to primary prevention programs. We aim at, or we look at the risk factors, and we want to modify these risk factors. So when we said that smoking is a risk factor, cessation of smoking is a primary prevention. Hypertension is a risk factor, so to control the hypertension. Because when we control the hypertension with medications, in order to maintain the systolic and diastolic blood pressures to their normal levels, then the injury to the blood vessels will be diminished, and there will be slowing of the progression of atherosclerosis. Also, weight loss and exercise, all of these will decrease the LDL blood cholesterol levels. Also, other measures to decrease the LDL levels in the blood and increase HDL levels as the diet and statins that are lipid lowering drugs. Now, as I said, in the secondary prevention program, we want to prevent the recurrence of any event like myocardial infarction or stroke in patients who are symptomatic or who experienced one of these complications. You don't want these complications to come back. And the secondary prevention involves the use of aspirin, which is an antiplatelet agent to prevent the or decrease the risk of thrombosis, مميع الدم. Statins برضو, they are lipid lowering agents or drugs to treat hyperlipidemia. Beta blockers to decrease the workload on the heart. These are medications that decrease the heart rate and the cardiac output. And sometimes some surgical interventions in patients who need these surgical interventions, like the coronary artery bypass surgery, تغيير شرايين القلب، أو sometimes قسطرة, catheterization with insertion of stents، وضع شبكات, and so on. Now let's talk about another cardiovascular disease, the hypertension, a very common disease. Almost in every family you hear about hypertension. The definition of hypertension is elevated blood pressure. The normal level of blood pressure is 120 systolic over 80 diastolic. And the definition of hypertension is when there is sustained elevation not by one measure only. Sustained elevation of blood pressure more than 140/90 for in a patient for more than three readings, for example, then we diagnose hypertension. So one time of elevated blood pressure, it is not called hypertension. It has to be sustained. And it is one of the major modifiable risk factors for atherosclerosis. Now, what is the pathogenesis of hypertension? In 90 to 95% of hypertension, of hypertensive patients, the disease is called essential idiopathic. Yani there is no known underlying cause. When we find an underlying cause in about 5% of cases only, this is called secondary hypertension. So most of the patients that we know are usually they have essential hypertension, either due to family clustering, family history, due to um, uh, some other diseases like um, diabetes also usually comes with hypertension, some familial clustering. The underlying mechanism or the exact cause of essential hypertension is not known. That's why we call it idiopathic. يعني مش معروف سببه. في هاي الحالة we have to treat hypertension to prevent the complications that are associated with hypertension on the body. It is a chronic disease, and once the patient is diagnosed with it, he will be diagnosed for life. زي السكري. Those with the secondary hypertension, we should treat the underlying disease because many diseases can result in hypertension, like some renal diseases or renovascular diseases. أمراض في الكلى، الفشل الكلوي، تضيقات في الشريان الكلوي. We call it narrowing of the renal artery due to some diseases that can affect this renal artery. Also secondary to some endocrine disorders like those affecting the adrenal gland, hyperaldosteronism, Cushing syndrome, in which we call it also hypercortisolism, or a pheochromocytoma, in which there is a tumor in the adrenal gland producing epinephrine and norepinephrine. All of these, among others, a long list of causes can lead to hypertension. Even hyperthyroidism sometimes can cause hypertension. In all of these cases, we have to treat the underlying cause, and subsequently the hypertension will disappear. When we talk about hypertension, we have to mention a few words about malignant hypertension. Malignant hypertension is a misnomer because it's not malignant, it's not cancer, but it is to imply how dangerous hypertension is in these patients. In about 5% of hypertensive patients, they develop a rapidly rising blood pressure that, if untreated, leads to death within 1 or 2 years. This is called malignant or accelerated hypertension. The clinical syndrome of malignant hypertension is characterized by, first, severe hypertension, in which the diastolic blood pressure, the diastolic, not the systolic, is more than 120. And it is usually associated with renal failure, فشل كلوي, and retinal hemorrhage, نزيف على شبكية العين. This triad is called malignant hypertension. So it's not only the elevation, it is the associated syndrome with this elevation, and this will put the patient on a high risk of sudden death. Now, vascular pathology in hypertensive patients. How are the vessels are affected in patients with hypertension? First of all, as we discussed earlier, it accelerates atherosclerosis because it is one of the risk factors for atherosclerosis. And more atherosclerosis is associated with more hypertension. So it's like a vicious circle. Another vascular pathology is that hypertension induces degenerative changes in the wall of blood vessels, and this can lead to hemorrhage or rupture of these blood vessels. Sometimes the hemorrhage, if it is in the brain, it can result in stroke. Another complication is in the small blood vessels, which are called the arterioles. The arterioles are usually spared from atherosclerosis. However, they are affected by other diseases in patients with hypertension. We call them hyaline arteriolosclerosis and hyperplastic arteriolosclerosis. Let's start with hyaline arteriolosclerosis. We call it hyaline because of the deposition of مادة hyaline-like pink material in the wall of the arterioles, causing thickening of the wall. يعني بيصير الwall of the blood vessel thick with corresponding narrowing of the lumen, والlumen بيصير متضيق. Frequently, this is seen in elderly patients, not necessarily to have hypertension, whether normotensive or hypertensive. So hyaline arteriolosclerosis is not a feature that is only seen in hypertension, can be seen in elderly patients, even who are normotensive, but it is more generalized and more severe in patients with hypertension. Also, we can see it in patients with diabetes, the hyaline arteriolosclerosis. So it's not only seen in hypertension, but it is one of the vascular pathologic changes that are seen in arterioles in patients with hypertension. The second pathology is hyperplastic arteriolosclerosis. It is related to more acute or more severe elevations of blood pressure, not only the presence of high blood pressure. It is a characteristic feature of malignant hypertension, but it's not limited only to malignant hypertension because it can be seen in even the non-malignant hypertension. The problem with the hyperplastic arteriolosclerosis is that it is associated with acute cerebral injury and acute renal injury. So they can result, for example, in a renal disease or in a cerebral stroke, for example, cerebral disease. Microscopically, these arterioles have a characteristic onion skin thickening of their walls with narrowing of the lumen. So in hyaline arteriolosclerosis and in hyperplastic arteriolosclerosis, we have narrowing of the lumens of the arterioles. In the hyaline arteriolosclerosis, there is a deposition of pink hyaline material, and in the hyperplastic arteriolosclerosis, histologically there is an onion skin-like زي قشرة البصلة, and you will see a picture in the next slide. So here you can see the first picture here, in which we have this pink material deposited in the wall of the arteriole with narrowing of the lumen of the arteriole, so subsequently the blood flow will decrease. This is called a hyaline arteriolosclerosis, and in this picture here, this is from the kidney. It is associated with renal injury. This is the arteriole. Look at the lumen is very narrow, and the wall of the arteriole is like the onion skin, مثل قشرة البصلة. So now let's shift to the cardiac diseases of the heart. Diseases of the heart, we will have a little bit talk about the heart failure, left-sided heart failure and right-sided heart failure, and we will talk a little bit about the ischemic heart diseases. As you know, the heart is subdivided into left side and right side. The left side, the left atrium and the left ventricle, in between them we have the mitral valve and we have the aortic valve, from which the blood escapes from the left atrium to the aorta. And the left side of the heart pumps blood to the systemic circulation, to the rest of the body. So the power in the left side of the heart is high, the pumping capacity. The right side of the heart usually receives the blood from the systemic circulation through the inferior and superior vena cava, and then it pumps the blood through the pulmonary artery to the lungs to get oxygenated there, and then it gets back to the left side of the heart. So diseases that affect the left side of the heart, the causes of the left-sided heart failure There are many causes. The first one and the most common one is ischemic heart disease due to ischemia. And ischemia, then back to the causes of ischemia to the heart, coronary artery disease and coronary artery atherosclerosis mainly. The ischemic heart disease, if it is chronic, if it is associated with multiple myocardial infarction, can result in left-sided heart failure. Then we have the systemic hypertension also, because systemic hypertension, if you remember from the cell injury lecture, we said that the heart to adapt will undergo a pathologic form of cardiac hypertrophy. This cardiac hypertrophy في البداية it will increase the cardiac output, لكن with time the heart will enter into a failure state. يعني راح يتعب الهارت وبيدخل بهارت failure. Any mitral valve disease or aortic valve disease like the mitral stenosis or mitral regurgitation, aortic stenosis or aortic regurgitation يعني سواء تضيق في الفالف أو ضعف في الفالف راح يؤدي إلى left-sided heart failure. And at the end some myocarditis, inflammation of the heart muscle, or some inherited forms of cardiomyopathies affecting the cardiac muscles also can result in a weak left side of the heart وبالتالي left-sided heart failure. يعني left-sided heart failure هو عبارة عن ضعف في عضلة القلب من الجهة اليسرى. What are the symptoms? And we call them the clinical features, الأعراض السريرية ل left-sided heart failure. The most important symptom is the dyspnea. Dyspnea on exertion usually. On exertion يعني لما البيشنت يبذل مجهود. It is the earliest and the most significant symptom of left-sided heart failure. Dyspnea is shortness of breath يعني صعوبة في التنفس أو difficulty في breathing. The second symptom is cough يعني الكحة with expulsion of frothy sputum. frothy يعني بيكون زي الرغوة. C orthopnea. Orthopnea, it means difficulty of breathing. It is a dyspnea, but it comes when the patient is in the supine position or in the recumbent position. يعني لما يكون البيشنت متمدد بيزيد ال venous return to the heart وبالتالي بيزيد تدفق الدم لللنجز وبالتالي اللنجز because the left side of the heart is in a heart failure state it will not receive the blood coming from the lungs efficiently فراح يصير في congestion of blood congestion in the lung والpatient بيصير عنده صعوبة في التنفس لما ينام. that's why it is طبعا relieved by sitting or standing. That's why الpatients اللي عندهم left-sided heart failure دائما بتلاقوهم نايمين on extra pillows. دائما بينام على أكثر من مخدة عشان يتفادى إنه يصير عنده الأورثوبنيا. Another symptom is the paroxysmal nocturnal dyspnea. شو يعني paroxysmal؟ يعني بيجي فجأة sudden onset. Nocturnal يعني إيش بيجي at night. وdyspnea we discussed it. It is the difficulty in breathing. So paroxysmal nocturnal dyspnea is difficulty in breathing that comes suddenly and awakens the patient from sleep at night with the feeling of suffocation. يعني بيكون المريض حاسس حاله بده يختنق فبيقوم من النوم مفزوع وبيروح للشباك أو أي مكان to get air inside his lungs, a feeling of suffocation. This is typical in patients with left-sided heart failure. Also من الفيتشرز اللي هي usually we find it on auscultation. لما نسمع الchest بالستethoscope we hear fine rails أو crepitations at the lung bases وسبب هاي الكريبيتيشنز هو إنه بيكون في تجمع سوائل pulmonary edema تجمع سوائل نتيجة الcongestion اللي بيصير في اللنج. الدم ما بيرجع مظبوط للليفت سايد اوف ذا هارت لانه في failure state فالدم بيصير له congestion في اللنج في البلمونري circulation وبصير في عنا pulmonary edema. وهي البلمونري edema هي السبب في الكف وفي الديزنيا والباروكسيزمال نكترنال ديزنيا والأورثوبنيا كلياتها. فإحنا بنسمع صوت طقطقة أو ترتقة خلال عملية الأوسكلتيشن. كمان من الفيتشرز of left-sided heart failure is diminished cardiac output. This is يعني logic لأنه ال left side of the heart is in a failure state، فبالتالي ال pumping capacity تبعيته بتقل، وبالتالي ال cardiac output بقل، وتبعا لذلك ال blood flow لل cerebral circulation بقل، لل renal blood vessels بقل، لل intestine بقل، لأي أي part من البودي، حتى لل peripheral skin، لل peripheral extremities، ال blood flow كلياته بيكون diminished and decreased. Now we come to the right-sided heart failure اللي هي ضعف عضلة القلب من الجهة اليمين. Usually the most common cause of right-sided heart failure is left-sided heart failure. It is a consequence of left-sided heart failure. Other causes of isolated right-sided heart failure يعني لما يكون في عندنا right-sided heart failure لكن ال left side is normal. First, severe pulmonary hypertension resulting in right-sided heart failure. البيشنت بيكون عنده disease in the lungs سواء interstitial lung disease or whatever causing elevated pressure in the pulmonary circulation, and this will cause a backward pressure on the right side of the heart causing cor pulmonale. We call it في هاي الحالة cor pulmonale, right-sided heart failure secondary to pulmonary hypertension. Second, pulmonary or tricuspid valve disease. Again, stenosis or regurgitation of these valves can lead to right-sided heart failure. And third, the congenital left to right shunt بحيث إنه أحيانا بيكون في عنا فتحة في القلب ventricular septal defect between the right ventricle and the left ventricle. And because the pressure in the left ventricle is high, so there will be a shunting of blood from the left side to the right side. This will place the right side of the heart on high pressure and will lead to right-sided heart failure. The clinical features of right-sided heart failure are different from left-sided heart failure. But if the patient have a congestive heart failure, which is left side and right side, he will have the clinical features of both. But the clinical features of right-sided heart failure are usually related to systemic and portal venous congestion. There is a إذا بتذكروا بوقت الهيموداينامكس lecture لما حكينا عن الكونجستشن الجنراليزد كونجستشن بيصير بالناس اللي عندهم رايت سايدد هارت فيلير لانه البلد الفينس ريتيرن تو ذا هارت بقل لانه الهارت از ان ا فيلير ستيت فكل هذا الفينس بلد رح يتجمع ويصير له انجورجمنت في البريفرال فينز فهذا الكونجستشن رح يؤدي الى edema of the lower limbs peripheral edema and ascites which is edema fluid accumulating in the abdominal cavity also due to congestion of the venous portal venous circulation راح يصير في enlargement of the liver hepatic enlargement and enlargement of the spleen splenic enlargement and also these patients will have pleural effusion it's edema everywhere pleural effusion that's accumulation of fluid in the pleural cavity so as you can see here, right-sided heart failure is not associated with pulmonary edema in the lung tissue itself. It is associated with accumulation of fluid in the pleural cavity. We call it pleural effusion. The second part of the heart diseases is the ischemic heart disease. Very common disease. Also, we can call it coronary artery disease because in more than 90% of cases of ischemic heart disease, it is due to coronary blood flow limitation, most commonly secondary to atherosclerosis, تصلب شرايين القلب. Now, the clinical presentation of ischemic heart disease is variable, and it depends on the degree of occlusion for the coronary arteries by the atherosclerosis or by the superimposed thrombus. The presentation can be seen as angina pectoris with its variable types of angina, the stable angina والunstable angina والvariant angina, and the myocardial infarction, which is the total occlusion of the coronary, which is due to total occlusion of the coronary artery by a thrombus. Now, let's start with angina pectoris. angina أو ما يسمى بالذبحة الصدرية هي عبارة عن intermittent chest pain وجع في الchest caused by the transient reversible myocardial ischemia. So it's a transient, just for a short period of time, and it's reversible. So there is ischemia, but this ischemia is followed by a state of perfusion of the for the heart muscle. So there is no total loss of blood supply. The problem with the angina is that there is coronary atherosclerosis in more than 90% of cases. And this atherosclerosis of the coronary arteries will lead to narrowing of the coronary arteries and to decreased blood flow to the heart muscle. So during resting periods, the blood flow is adequate. However, if the heart muscle needs to work more, like on exertion or when exercising, the blood flow become inadequate and the patient starts to complain of chest pain. This is the typical angina, or we call it stable angina. Why it is stable? Because it comes only on exertion على الجهد, it is relieved by rest or by drugs, like the patient takes the sublingual nitrate تحت اللسان لتوسيع الأوعية الدموية. The cause for stable angina is atherosclerotic lesion that causes 70% occlusion of the vessel. So it's only 70%, وهي كافية في أوقات الراحة ولكن ما بتكون كافية لما الإنسان يبذل مجهود. النوع الثاني من الأنجينا اللي هي الانستابل أنجينا، وهون هاي بنسميها أحيانا كريسندو أنجينا. هاي المشكلة فيها إنه الأوكلوجن is 90% of the lumen of the blood vessel, so it's not even adequate at resting conditions. So the patient will experience the pain at rest, and this is a dangerous hallmark when the patient starts to complain of chest pain at rest. This means that he is at high risk for the development of myocardial infarction later on. So those patients with unstable angina, they even are admitted to the hospital and they are treated in the hospital to relieve the obstruction either by catheterization and stenting or by other means. The other type of angina is called variant angina. Here there is no atherosclerosis and no narrowing of the blood vessel. It is just caused by arterial vasospasm, تضيق في انقباض في الارتري مما يؤدي إلى decreased blood flow to the cardiac muscle. But it is not that common when the patient comes with angina pectoris symptoms and we do all the investigations and the coronary arteries are normal even on catheterization and there is no atherosclerosis, so يعزى السبب للانجينال chest pain إلى vasospasm. So there is stable angina, unstable angina, and transmittal or variant angina. The other type of ischemic heart disease or coronary artery related disease of the heart is the myocardial infarction. The myocardial infarction is characterized by infarction, death, necrosis of the heart muscle نتيجة الإسكيميا. And here it's different from angina, but usually it is preceded by anginal chest pain due to the atherosclerosis. The pathogenesis here is caused by complete obstruction of the coronary artery by a thrombus. This thrombus usually comes over or it is superimposed on an atheromatous plaque, and it can cause a massive myocardial infarction. Sometimes, in about 10% of cases of myocardial infarctions, it occurs in the absence of atherosclerosis and it is related here to vasospasm. But this is a rare or an uncommon scenario. The most common scenario that the patient is already having atherosclerosis and there is rupture of the atheromatous plaque and with superimposed thrombus that totally occludes the blood vessel with resultant loss of blood supply to the cardiac muscle resulting in necrosis. The clinical features for myocardial infarction is different from anginal chest pain. Although both of them will experience the chest pain, but the symptoms associated with myocardial infarction are much more severe. The pain in MI is characterized by being severe, crushing, substernal below the sternum chest pain that usually radiates. يعني البيشنت بيحس بالألم بالchest وبيروح لأماكن تانية زي للنك للإبيجاستريك area أحيانا to the jaw and أحيانا to the left arm or left shoulder. In 10 to 15% of cases MI بتكون silent MI that is without symptoms, and this is common in elderly patients and patients with diabetes. So we should be cautious إذا البيشنت elderly أو diabetic and he started to experience the other symptoms of MI like sweating for example and the nausea but without the chest pain. This is called silent MI. Although also of the clinical features the rapid and weak pulse اللي هو نبض القلب بيكون سريع ولكنه weak ضعيف. nausea الشعور بالغثيان and sweating التعرق الزائد. This is typical for MI. This is usually not seen in anginal chest pain. It's only seen in myocardial infarction or أحيانا في unstable angina. In addition, the patient also may experience dyspnea, which is shortness of breath. And the cause for dyspnea in MI is if it is associated with left-sided heart failure and acute pulmonary edema. So the patient will start to complain of shortness of breath because as we said previously that one of the causes of left-sided heart failure is the ischemic heart disease. So these are the symptoms of MI. The symptoms of angina are usually less severe and especially with stable angina it comes on exertion and it's relieved by rest. بينما في MI the symptoms are more severe and they are prolonged. They continue for a longer period of time, not relieved by medications, and at this in these instances the patient should be taken to the emergency to do the laboratory investigations and to find if he is having MI.